Okay, we're live. Just waiting for Dr. Rachel Bond, cardiologist, to jump in the room here. There she is. I got a little music playing here because you all know how I operate. I gotta have some music playing. So let me see if I can figure this out. I always forget. Hi, Dr. Bond, I see you. How do I do this? I always forget. I think I clicked this little camera thing. There she is. Send request. Hi, everybody. Good morning. If you're in Arizona land, Dr. Bond.
Hi, how are
Yes.
you?
Oh my gosh, I'm doing okay. How are you?
I'm doing well.
Thanks for agreeing to do this.
Yeah, of course.
At the Aura presentation was so cool. I mean, they did a really great job this year, and it was really neat hearing your presentation. Um, and I'm familiar with the interface between cardiology and rheumatology, but I've never really heard anybody mention that term cardiorheumatology. So that was so cool to me.
Yeah, I'm trying to get the word out there that we definitely have this collaboration in the rheumatology and cardiology world, and we need to expand on that.
Yeah, well, before we dive into the meat and potatoes here, or for the plant-based folks out there, the tofu or the tempeh and the green, I want to ask you a fun thing about yourself, which is who's your favorite superhero?
Oh goodness. Okay. Well, so I personally am more of a Disney princess person.
Oh,
However,
okay. Well, we can stop there and ask you who's your favorite Disney princess. I know who mine is.
so mine actually is the Little Mermaid. I was obsessed with her since a child, and I think that the story in of itself is, now I can say that there are some aspects of it that hopefully Disney, looking back, could change to some degree in the sense that she needed her voice and needed a man to get her voice back. However, what I will say is that the ability to be yourself and really tell your family that you want to make those changes because this is your true self is really what I valued as a child. And I love swimming and I love the ocean. So that's why the Little Mermaid for me. But if I were to choose a superhero, I would absolutely say Wonder Woman.
Awesome. Wow, I like that. Well, I want to chip into what you said a little bit there. And I'm a naturopath, as you probably know, scoping me out. But so I look at these more intangible things in terms of what can like perpetuate disease process. And I think
Yeah.
like a betrayal of self or deception of self, and people don't express who they really are. They don't speak their voice, and that's much harder for women to do, obviously. And so thank you for bringing that up. So the Little Mermaid, yeah, Ariel, and it has the
Ariel.
best Disney scene ever, which is that little thing with Sebastian going off and singing about life under the sea.
Oh, yes, absolutely. I love that. I love every song actually in that. And I just saw a commercial recently where I forget which brand or company it was, but they were reenacting it, which is a very genius idea.
Beautiful. I'll buy whatever they're selling.
Ever.
Hey, so tell everybody why you do what you do and how you got into it.
Yeah, so first of all, I'm a cardiologist and there's different aspects of cardiology. So I focus on the preventive aspect of it. And really what drove me to that was during medical school and more importantly, residency. I realized that I was seeing so many patients coming in, actually at very young ages with cardiovascular complications. And I wanted to make it my life's mission to really focus in on the preventive aspects, understanding that heart disease is something we could prevent 80% of the time. The populations that I focused most on are those vulnerable populations, such as women. There are gender disparities. I oversee in one of the larger hospitals in Arizona our women's cardiovascular program. And beyond that, I like to also focus in on usually communities of color as well, because there's vulnerability to that too. So that's what really drove me. In addition, I can say from a personal perspective, I saw some family members that at early ages were being diagnosed, and a lot of it had to do just with poor health literacy, doctors not communicating well with the patients. And I really wanted to, after seeing what they went through, again, make it my life's mission to try to hopefully make those changes.
Awesome. So you said you mentioned two things that I want to hit on, which is there was this influx of the younger population, which is kind of odd to think about for most people, right? Because it's like cardiovascular disease is usually a disease of the wiser population. So this influx, you mentioned poor health literacy. Can you expand on what that means? And then my other question is, does this have anything to do with rheumatologic disease?
Absolutely. So, what we are seeing is over the past 4 decades, even 5 decades right now, that we have done a phenomenal job in the cardiology world in creating new innovative procedures that are life saving, even medications that are life saving. And I do believe we've done a better job in communicating lifestyle, because I can't emphasize enough the importance of exercise and eating healthy in terms of lowering your risk of cardiovascular complications. However, most of that has been in the wiser population, as you very nicely said. So those usually above the age of 65. Where we haven't seen as well a turnout has been in the younger population, more importantly, 35 to 54. And there are gender disparities that we see along those same lines. A lot of it, unfortunately, has to do with us unconsciously not providing the same guideline medications to a female as we do to a male, or not as aggressively managing their conditions, because in of itself, women may present with more atypical or non-classic symptoms of heart issues, as an example. Where rheumatology very nicely falls into this is because that is our most vulnerable patient population, we're trying to find out ways to collaborate with other specialists that deal with a lot of more female predominant conditions. Rheumatologic disease is much more common in women than men, specifically our diseases like lupus or rheumatoid arthritis, as an example. So because of that, we know that it's disproportionately affecting women. However, in of itself, as an inflammatory disease, it does place that patient at a higher risk of having heart disease. Why? Because heart disease is an inflammatory process. We're learning that. So that's why we're targeting that collaboration with rheumatology or primary doctors or naturopathic doctors like yourself who really hone in on those rheumatologic conditions. I will say that another area that I have collaborated immensely with is also the obstetricians, because we know during that age period, they most likely are thinking about pregnancy. And a lot of the complications that occur with pregnancy, such as diabetes with pregnancy or blood pressure issues with pregnancy, can actually put them at a higher risk in the future of heart disease as well. So we really want that collaboration, without a doubt.
Awesome. Is the preponderance of the younger demographic that you're seeing more because of these unrecognized inflammatory conditions, or do you think it's more of a function of just lifestyle and diabetes and being overweight? What have you seen there?
I can say that I think it's a multitude of reasons. One is that we, at least in cardiology, don't do as good a job in enrolling these younger patients in our research trials. So is it possible that they would be treated a little bit differently than our wiser population? I'm sure the answer is yes. However, we haven't been able to really get a large enrollment. And that's not because the patients are not thinking about it. It's just because we in the field are not doing as good a job in targeting them. Secondly, I will say that I do believe it has to do with the fact that those conditions are not thought of as well as clinicians. No one, for the most part, if somebody presents with lupus as an example, are going to naturally think, well, your risk of heart disease is actually 5 to 7 times that of somebody who doesn't have lupus. And that's really where educational things like this, I think, come into play, because we do want to empower the patients to understand their risks, knowing heart disease, irrespective of if you have lupus or if you've had complications during your pregnancy, or even furthermore, for a female perspective, I work very closely with oncologists, because breast cancer therapies, a lot of the chemotherapeutic agents and the radiation therapy can take a toll on the heart. And what I will say is that irrespective of any of those conditions, heart disease is our greatest threat. It's our greatest threat, of course, as we get older, but what we do during our younger years dictates what happens to us in our 50s, 60s, 70s, etc.
Gotcha. So you hit on three components here. Gosh, I feel like I should be taking notes. So we've got a research problem in the younger demographic. And I hear that often. Oh, well, you're not old enough. You're not, it's like ageism against young people. We got under recognition here, and then we've got these lifestyle parameters. Can you talk about how heart disease kind of atypically presents in females?
Oh, absolutely. So I think the first way we can do that is by talking about that typical presentation. So when you think about typical classic symptoms of a heart attack or heart disease, you think about, you see it in the movie, somebody clutching the center of their chest. They may describe it as an elephant sitting on their chest. They also may describe it as coming on with exercise or stress and then going away with rest as an example. It may radiate down their left arm or to their jaw. They may feel nauseous, etc. With women, they do feel those symptoms, but then there's a third of the time when they may not experience any symptoms, such as chest discomfort. They may experience more shoulder pain or neck pain. They may feel short of breath with exertion. They may even feel just fatigue or tiredness. And I do stress that because a lot of women present with early signs of tiredness that could be a red flag that there's something going on from a heart perspective. In this day and age, I know it's very hard to differentiate tiredness from work and stress, etc. But if that tiredness is perseverating, meaning not going away, and even if you got a good night's sleep and you're you're focusing on mental wellness, etc., you have to think about talking to your primary doctor about, is this something going on with my heart, especially if you have any risk factors for heart disease.
Can you run through those risk factors for everybody real quick?
Yeah, so the risk factors that we commonly think about are family history. So we know that having a first degree relative, which means mother, father, or sibling, specifically if it's a male relative before the age of 55 who had a heart complication, or a female relative before the age of 65 who had a heart complication. Then there are more of those traditional risk factors, and it's those traditional modifiable risk factors, meaning the ones we can change, that actually make heart disease preventable 80% of the time. So that includes blood pressure, diabetes, high cholesterol, if you're a smoker, if you drink alcohol in excess, if you have lack of physical activity, and of course, if you're not eating a good, heart healthy and well-rounded diet. So those are the things that we like to focus on. And I alluded to a few of the less classic risk factors like rheumatologic conditions and pregnancy-related issues and possibly even breast cancer treatment. I will say also that chronic stress, depression, and anxiety, those are risk factors for heart disease. And obviously with this pandemic, we've seen that without a doubt increase in intensity. So it's very important that we are screening our patients for these conditions, but also providing them appropriate outlets to better manage these unfortunate situations.
I want to jump back to this fatigue element, and I work with a rheumatologist here, and I'm a little bit more sensitive in approaching fatigue, and she's like, fatigue, everybody's got fatigue. But it's so, like, where do you draw the line in like paying attention to that versus not? And then the other question is, what's like the timeline on this as an indicator for heart issues? And if I'm trying to articulate myself better here, but how long would this be going on as like an indicator of something that could be wrong with the heart?
Yeah, it actually does not need to be going on for a long period of time. What I will say is that it's that fatigue that's not going away that in of itself should prompt you to see your doctor, right? They may check a series of tests to make sure you're not anemic. Even so, maybe make sure that you're not having a inflammatory condition or rheumatologic condition. There are other aspects of what can cause fatigue. If those aspects are ruled out, meaning that we do not see any evidence of that, and you additionally have other risk factors that place you at a higher risk for heart complications, then I would say it would be actually very reasonable and wise for us to consider either doing imaging of the heart or referring that patient to a heart specialist just to make sure that we're not missing anything.
Gotcha. And then there's a lot of other factors that go into the soup, obviously, like these risk factors that you talked about.
Yes.
Okay. Can you kind of zoom back out and define what cardiorheumatology is? What does that mean? Tell us about it.
Yeah, so cardiorheumatology is an evolving field. It's actually not new. It's been around for some time, but I think hopefully we're going to get it out there more to mainstream to understand that connection. But what it is really a field of collaboration between a cardiologist as well as somebody who treats patients with rheumatologic conditions. And what we know is that if you have rheumatologic disease, you are at risk of having a much higher risk of having a cardiovascular complication. So that doesn't necessarily mean cardiorheumatology is only focusing on patients who already have signs or symptoms of heart disease. It's really even taking it as early back as we can to prevent that from happening. And that's where that collaboration, I do believe, is more thoughtful.
Gotcha. So you mentioned this fatigue element, kind of these atypical signs. What are other, I mean, there's obviously the baseline risk that you mentioned. What are some other indicators that we need to approach some of these patients with rheumatologic disease more sensitively? Obviously, we don't just want to precipitate cardiology consults for everybody.
No, absolutely not. And what I will say is that a lot of this can and should be done by the primary physician, if that's the rheumatologist taking on that role, or if they have a collaboration with a primary clinician. I do think that that's where, again, this education comes into play, because for any person who has an autoimmune condition above the age of 20, at least every few years, if not on a yearly basis, depending on as we get older, we should be checking your cholesterol levels, your blood sugar levels. Again, those more traditional risk factors, making sure your blood pressure is under control, and also considering doing a baseline electrocardiogram, which is basically just the stickers we place on the heart that allow us to look at the electrical conduction. That as well could, if there's abnormalities, drive us to think about getting you into the arms of a cardiologist or a heart specialist who may consider doing further testing. To date, we in the cardiorheumatology field are trying to figure out, should there be additional tests, sometimes looking at other inflammatory markers in the blood, or maybe doing more imaging of the heart to better delineate if that person has evidence of disease even before having symptoms. So I am hopeful that as this field evolves, we will figure out the best way to prevent this condition from happening. But I think the first step is making sure that if you do have an autoimmune condition, you know what your cholesterol is, you know what your blood pressure is, you know what your blood sugar is. And if you don't know that, you need to ask your doctor to check it, because the likelihood is it may not be normal, and you can hopefully prevent yourself from having any issues in the future once you figure it out.
Awesome. I'm remembering something that you talked about during your presentation, which was kind of this paradox where the lipids are kind of discordant with some of the inflammatory markers. Can you talk about that?
Yeah, so that's more specific for rheumatoid arthritis, where you may actually see that your lipid panel looks good, it looks ideal. But what you then see when you take it a step further is that those inflammatory markers are slightly out of whack. And in cardiology right now, we're looking at a lot of the little proteins that come off of the cholesterol panel. We're also looking at some of those inflammatory markers. One in particular is your high sensitivity C-reactive protein or peptide. It's sort of a protein that the body produces sometimes too much of in an inflammatory state. And the reason we're looking at that, as I alluded to, is that heart disease does have an inflammation component to it. So if those levels are high, sometimes that may tell us as doctors, and not just cardiologists, but also primary clinicians, etc., that maybe we need to treat these patients more aggressively with those traditional risk factors. If lifestyle, changing your diet, exercising more is not helping, then that's sometimes where medications may have to come in. So although there is this paradox with rheumatoid arthritis, what we do in those populations is we're usually a little bit more sensitive in checking those other markers to better figure out what their overall risk is.
Gotcha. So, like the way I was trained as a naturopath, and this is more like a clinical question, and there's probably a lot of nuance to it, but like, oh my gosh, you see an elevated high sensitivity CRP, and it's like a 2, you need to freak out, bells, whistles, get all this stuff going on. Do you have like a cutoff for that, where it's like we really need to do something versus not? I mean,
Yeah.
and kind of like my impression of the way rheumatologists are. And I'm not trying to bash on anybody here, but it's like, oh, you got a CRP of like 8. A regular CRP, who cares? Whatever. I've seen CRPs 30, 60, 100. So like with respect to the high sensitivity CRP, is there like a cutoff where you're like, we need to get more aggressive versus not?
Absolutely. So there was a very large trial, landmark trial that looked at this, but what I will say is that they did not test this in patients that have inflammatory conditions. So it's hard for us to say what is the best cutoff for those that have it. They tested it in the general population that did not have any form of inflammatory disease. What that cutoff was actually 2, but that didn't necessarily imply at 2 or above 2 we should immediately put them on a medication that will help lowering that level of a CRP or lower that level of cholesterol. What it told us was that maybe more testing is necessary. And that's a lot of times what I'm doing, just anecdotally with my patients. I'm not going to rush to get them on a medication. I want to focus on lifestyle, but I may do more testing of their heart. Now in cardiology, we've come a really long way, and we have access to testing such as calcium scores, which are basically X-rays that allow us to see if there's any calcium in the artery of the heart. And that calcium is plaque that's built up. And if there's evidence of plaque, by definition, you have heart disease, even if you don't have symptoms, right? You could have plaque there, but that plaque may not be causing an obstruction or a blockage. And that's why you're not having symptoms, but we don't want to ignore that plaque. We want to be very aggressive in treating it. And the best way we know how to treat it is typically with cholesterol medications, baby aspirin sometimes, depending on how high that burden is. And then absolutely lifestyle, which I always tell my patients is probably the most important thing at the very top of the list.
Thank God for you. It's like, did your doctor talk to you about diet, exercise, go to bed on time, watch some Happy Gilmore? No. What? I have so much energy. Okay. Where did I want to go next? So you talked about some of these more advanced lipid screening things, and these always kind of confuse me a little bit. And you know, people do these expensive cardiometabolic tests with this NMR profile and this and that. Can you talk about those and the necessity of those versus not?
Yeah, so about a decade ago, we were really delving deeper into the lipids in the sense of figuring out if one size is more at risk of having heart disease in that immediate period or even the future than another size, larger lipid particles versus smaller lipid particles. And the rule of thumb right now is that we're really not focusing in on that as much as we are on the proteins that come off of it. So there are a lot of different molecules and proteins that come off of the lipids, such as lipoprotein little a, apolipoprotein B. So these are terms that obviously I don't expect someone in the layman's community to understand, but these are terms that it's very important your clinician understands. Because if there are questions about what your risk is, and we have the ability right now to actually calculate one's risk because we have risk equations and other aspects, but if there are questions about if your risk is in that borderline range and your doctor or clinician are on the fence about thinking about putting you on a medicine to lower your risk of heart disease, and that medication would be like a cholesterol medication as an example, we can do additional testing. Even if we don't want to think about a medication and we want to get a better risk overview or assessment, we can do those additional testing. And that's where this blood work really comes into play. And sometimes, as I alluded to earlier, I do take it a step further where I don't just do the blood work, I also do this calcium screening. because I do think that the calcium screening has really changed the game for preventive cardiology, where we are able to diagnose a little bit earlier on if there's any evidence of plaque in the arteries of the heart by actually visually seeing that plaque.
Gotcha. Um, so these apolipoproteins, I just want to make a comment there on kind of my understanding, and correct me if I'm wrong. I
Yes.
see them often, the ApoB, the ApoA, sometimes the LDLP,
Yep.
and I give less credence to particle character or quality, fluffy versus small, dense. My understanding was it's like in that realm, the more of the total particle number than the character. Is that silly thinking? Is that correct thinking? What are your thoughts there?
No, that's not silly thinking. That's actually appropriate thinking. And I think the beauty is that we do now have a series of different tests that we can utilize, right? It's not always a good idea just to have one test because there may be discrepancies, as you alluded to, even in our rheumatoid arthritis patients, their lipid panel may look perfect and ideal, but if we checked their ApoB or their lipoprotein little a, it may not demonstrate the same. So I really do encourage for those patients that have a heightened risk of cardiovascular disease that we're checking a series of different agents or different proteins, such as, again, a standard lipid panel, but also considering having your clinician consider the use of these other proteins as well.
I want to reiterate what you said, which is like this is like a stew with a lot of different ingredients, and you
Yeah.
don't want to just pay attention to one marker. You want to look at the whole person, their environment, their risk. Great, great, great point. Somebody has just posted a question, and I think there's a little bit of unclarity with respect to the calcium score, and they asked if it was a lab test. Is there a lab test that kind of predicts what your calcium score is going to be, or is that strictly imaging?
So a calcium score is strictly imaging, and it's actually very different from the calcium that's in your blood. So having changes in calcium in the blood should not actually alter the amount of calcium we see in the arteries of the heart. The reason is that calcium is actually just plaque being fat or cholesterol that's hardened over and has been there for a period of time. In the cardiology world, we have come out with guidelines, and we state that those that have a family history in some first degree relative of premature heart disease, who are above the age of 40, and possibly other risk factors would qualify from getting this imaging test, which is a calcium score. And because it's an imaging test, for all intents purposes, it's like an x-ray of your heart. It has a very low amount of radiation. When we think about the amount of radiation, it's probably equivalent to what we experience just naturally living in the United States for 1 year. So it's a very low amount of radiation. And what I will stress is that if that calcium score is 0, which is ideal, we do not want to have any plaque in the arteries of our heart, especially that has calcified over or hardened over, then we do not have to repeat it for another several years. And that will be at the discretion of your doctor. If it's positive, that will then put you in a much higher risk category where we would then talk about being more aggressive in managing your risk factors. So I do think it's a very helpful test, especially if you have just your traditional or even sometimes non-traditional risk factors for heart disease. But definitely talk to your clinician about it. They'll be able to expand on if you're the right candidate for this test or not.
Awesome. Are there any of these risk factors that you give more weight? I mean, in my mind, and please just like slap me around if I'm thinking silly here. It seems to me like that calcium score would be kind of like a final arbiter in decision making with respect to how you're going to intervene here.
It is. And that's, for the most part, it's been very helpful in helping us as clinicians to determine, do we intervene with medication or do we continue on with lifestyle measures, etc. What I will say is that there are some risk factors that actually affect different groups of the population. So as an example, I focus a lot on women's care. We know that having somebody who smokes cigarettes, women versus male, a female is 25% at a greater risk of having some form of cardiovascular disease compared to her male counterpart, irrespective of if they smoke the same amount of cigarettes and for the same duration of time, which is really impactful. And I say that a lot to my female patients. Similarly, we know diabetes plays a much greater role in women than men in terms of risk for heart disease, where it increases the risk by about 3 times that in men, it increases it by 7 times in women. And we know also that being overweight, obese, physical inactivity, it does disproportionately affect women much more in the sense that it puts them at a higher risk for heart disease complications than men, in that it increases your risk of heart disease by 64% of the time, or 2/3 of the time, whereas in men it's about 46% of the time. So there are discrepancies in a lot of these risk factors that we see just based on our gender and or more importantly, our sex.
I'm getting educated hardcore here. 25 times the risk, way more risk. Women are hit harder smoking cigarettes than men. What the heck is the reason for that?
Yeah, and that's again where that research aspect needs to come into play. So there has to be something in that nicotine that is somehow just heightened, just targeting the vessel walls. And nicotine is obviously a substance that's in the vast majority of these cigarettes. And I will stress, it's not just necessarily your standard cigarettes, it's the vaping as well. And we know that that's epidemic in of itself, and something that especially in the younger population we need to really focus in on. And I work very closely with the American Heart Association in Arizona, but even also broadly nationally, and they're doing really wonderful campaigns to target this. But I will stress that more research needs to be focusing on the why behind this. We see that there are these discrepancies, but we need to better understand the why. But for the most part right now, regardless of what your sex or gender are, you just should not be doing any of these awful vices, I should say, because they obviously place you irrespective at a higher risk of heart disease.
I twinged a little bit when you mentioned vaping and a lot of my patients know I do it. I vape.
Ah, do you?
Wag
Okay.
your finger at me, Dr. Bond. Well, hey, I'm a guy, so I'm a little bit protected, maybe. Who knows? So can you kind of talk about how you approach lifestyle in some of your patients? Because that means a lot of things. And
Yeah.
can you dive into nutrition a little bit? Because people are confused. Yesterday eggs were bad. Today they're good for you. Tomorrow don't eat oatmeal. Oh, wait, let's do low-fat sugar again. So what the heck? What's going on there?
Yeah, so I reference a lot the American Heart Association, but it's a good reference, and they have wonderful resources because of the fact that they created something called Life Simple 7. So these are 7 easy steps that you can just focus on to live a much better, longer life, and more importantly, a heart healthy life. So first step, a lot of it has to do with knowing what your numbers are. So making sure your blood pressure is at goal, your cholesterol is at goal, your blood sugar is at goal. Eating healthy is part of that as well. Oops, I'm sorry, my AirPods are having technical issues. But making sure you're eating healthy as well. And when we think about eating healthy, we know that a more plant predominant diet is really what we in the cardiovascular field deem to be more heart healthy. So a lot of times that includes nuts, legumes, whole wheat, getting rid of that saturated fat, which a lot of times that saturated fat comes from red meat. So having more protein. And I say plant predominant because I know that for the most part, plant-based is probably slightly better, but we also want to be very thoughtful that we don't necessarily have to have all of our patients become vegan, etc., right? But of course, understanding that there is some data to suggest if you follow that sort of plant predominant diet, you can lower your risk of cardiovascular disease. So removing as much as that saturated fat, that red meat, having more protein like fish meaning the oily fish like salmon, tuna, because all of that has the really good healthy fat, which is the fatty acid, omega-3 fatty acid. And that's definitely helpful for us from a cardiovascular perspective. It lowers your triglycerides, which are the fat in your blood, and it helps to stabilize your cholesterol as well. We also know from a protein perspective, chicken without the skin and, more broiled or baked, these are options to think about. What I will stress that even though patients may be eating all the right foods, if they're having very large portion sizes of it, then that's still not helping, right? So you have to be thoughtful about your portion sizes. And that's where learning about the nutritional labels and how to read them really come into play. We know alcohol in excess is never good for us. Not only does it increase risk of blood pressure and heart disease, but also some cancers as well. So it's really suggested that women shouldn't have more than one glass of wine in that day, men no more than two in that day. We know, obviously, we talked about smoking and vaping and other aspects of that too. And that's what's all encompassed when we think about these 7 steps. And the last step is really physical activity. So when we think about physical activity, we know that at least 150 minutes per week of some form of cardio is what is suggested. And that could be moderate cardio, which includes walking at a brisk rate. So that's why I like to tell my patients that there should not be excuses, right? We should all be able to walk, go upstairs at our job. Be more thoughtful about maybe if we live in like a apartment complex or something, park your car a little bit further to force you to get that walking in for 30 minutes. We all have pets for the most part. I have a dog. I walk her quite often around my neighborhood. So it's something to think about. You could add it just naturally to your day-to-day, but making sure that that's within your day-to-day is going to be important, and it's going to lower your risk of heart issues.
Awesome. Yeah, get your movement in. No excuses. So there's a
Yeah.
rheumatologist in San Diego, Neda Yazdi, and she'll actually go out. I don't remember if she said in between consults or not. And I don't remember if she said she still has her white coat on and she's like doing stuff out in the parking lot. I was like, wow, okay.
Yeah.
Nobody
Yeah.
can make excuses.
Absolutely not. No, I mean, when I'm in the hospital, I use the stairs all the time just to, try to get in again. By the time I get home, it may be late, so you're exhausted, but just trying to use your environment as much as possible to get your exercise in.
Yeah. Do you have any input on supplements? I mean, it seems like everybody who comes in wants to be on more supplements, and they're always asking about this versus that, and the polyphenols and the omegas, and you talked about the omegas in the food, and this and
Yeah.
that. What are your thoughts there? Are there anything that you recommend to patients?
Yeah, so I say that obviously it's a conversation to have with your clinicians, right? If you're lacking something, then sometimes they could be reasonable. But I do stress that a lot of what we see, you can actually supplement in your diet, right? Where you don't necessarily have to take an extra pill. Most of the patients that are thinking about supplements are very resistant at times to being placed on pills. And if we can limit the amount of pills you have to take, I think that would be more practical. Maybe tweaking the diet a little bit. I would emphasize, there are wonderful registered dietitians out there as well who can help to focus in on, well, what would be an ideal diet for you, given your risks, given what you're looking to do. But a lot of the supplements that are out there in the world, you can actually achieve just by eating the proper foods. So, think about that. Just changing your diet maybe could prevent you from needing to be long-term on a supplement.
Well said. Speaking of supplements, I want to ask you about vitamin D and calcium. And the way I was trained was, if somebody's deficient, supplement them immediately. I think it's more nuanced than that, and kick them up to 70 because people are latitude hypothesis. People around the equator got this much sunlight, and this is where their vitamin D levels are. So, but I have reservation with respect to that, and I don't know what the degree of harm is in over supplementing with vitamin D and calcium, because obviously, you've got that calcium access and possible contribution to kidney problems, heart problems. Do you have any input there?
Yeah, so for that particular question, I would say that if there is a deficiency, and again, this is based on conversation with your clinician, but if there is a deficiency, then it is suggested that you actually are placed on the calcium plus minus vitamin D. What I have seen though is that some patients are being prophylactically placed on it. And I don't know if there's really any utility in doing that. And as you alluded to, it could possibly down the road, if causing changes in the structure or even the levels in your blood, it may lead to other issues, be it your kidneys, possibly heart, etc. So what I would say is that it's really important that if you're going to start taking anything, that you talk to your clinician before making that decision on yourself, because you don't know what the long-term outcomes can be. We know that the reason a lot of times patients started, or even clinicians more importantly started, is to prevent bone issues, right? Something called osteopenia, osteoporosis. We also know that walking, doing weight-bearing exercises, including walking as an example, help to prevent that as well. So this is, again, where it goes back to a lot of times lifestyle. If you're on that borderline range, having that conversation with your clinician, do I need these supplements? If the answer is yes, okay, having them make sure that they're following you closely. But if the answer is no, then I really would suggest against it, at which point you may want to focus more on changing your diet, exercising, etc.
Can you elaborate more on the medication side of things? And the first place I want to ask is, because this topic's still a little bit confusing to me, aspirin for primary versus secondary prevention. And I see like some of my colleagues are torn there, and it's like,
Mm-hmm.
especially when it comes to this autoimmune demographic, right?
Yeah.
This baby aspirin versus not, the risks. Oh my gosh, help us out there.
Yeah, so when we think about primary versus secondary prevention, I think it would be important to first define what that means. So, secondary prevention means that you already have been diagnosed with some form of cardiovascular disease. So, that could mean you had a stroke, you had a heart event, such as a heart attack, or you even have been diagnosed with blocked arteries in your lower legs or your upper arms, and we want to put you prophylactically on a medication to help keep that plaque that's there well controlled. In that situation, hands down, aspirin is 100% necessary. In situations, we may even want to do something a little stronger than aspirin, especially if we intervene, specifically, let's say, on your heart with a stent, which is basically a device that keeps a blocked artery open, or if you had open heart surgery. A lot of times in that acute period, they may put you on an additional blood thinning medication. And then eventually, you usually are able to get off of one of those agents, but for the rest of your life, you would need to be on that baby aspirin. And then we have primary prevention. That's where we want to prevent any disease from happening before it happens. So there's no evidence of any identifiable disease. And I will say that every 5 years, they change their recommendations. So it's very confusing. So where do we stand right now? Right now, they are saying that if you are somebody who does not fall into a intermediate or greater risk, you probably would not benefit from being on a baby aspirin, because we know that there are risks and benefits that come with aspirin. There's higher risk of bleeding, right? And that's something that we have to be very thoughtful of. And for me, whenever I talk to patients about what their actual risk is, I also weigh what their risk of bleeding is, if they have any bleeding disorders, if they're bruising, if they have other conditions that may place them at a higher risk of bleeding. We have to weigh those risks versus benefits. And if the benefit of that aspirin outweighs the possible risk of bleeding, then we get them on the medication. I will stress that a baby aspirin, although definitely can take a toll on the lining of your stomach, very rarely causes a life-threatening bleed. And the benefit of that aspirin, if you again fall in that intermediate or greater category, could be life-saving. It could prevent a stroke, it could prevent a heart attack, all things that could completely change your life altogether. But again, that's where talking to a doctor or a clinician really come into play, because they could help guide you and make it less confusing for yourself.
And I want to hit that again. Talk to your darn doctor. Get a health professional on board. Is it fair to say we would more likely start primary prevention with something mild like aspirin in some of these more of these autoimmune patients?
So again, and this is, I think, where the evolution of cardiorheumatology is going to take off, because we don't have guidelines right now for how we should best treat these patients with autoimmune conditions. What we are trying to think of is, should we be screening them more aggressively, where in addition to those blood tests, should we be offering them calcium scores? I bring up this because that's really the better imaging study we have to date to help us figure out if there's any evidence of disease before symptoms arise. What I will say is that if a calcium score is typically above 100, and it ranges anywhere from 0 till whatever, and when we think about the way to best define a calcium score, 0 to 10 is minimal, 10 to 100 is mild, 100 to 300 is moderate, and anything above 300 is severe. So once we get to 100 or greater, at least in cardiology, the cardiology world, we are suggesting that patients not only be started on a cholesterol medication like a statin, but they also are started on a baby aspirin. I will say that more research needs to be looked at in those more vulnerable populations, like our patients that have inflammatory or autoimmune conditions, because I can't answer that question fully right now. And what I will say is that every patient is very individual, right? So we want to make sure that we're taking every aspect of you and your history into account before making a decision about a medicine versus no medication. But again, I can't emphasize the importance of you seeing a clinician, getting all of these traditional things looked at, like your cholesterol, your blood pressure, and your blood sugar, because that will allow them at least to figure out what your risk is and then determine, would you benefit from aspirin, would you benefit from something else, etc.
Okay, that's awesome. And you answered a question that I wanted to ask but forgot to ask, which was where those cutoffs were in the calcium score before you move forward. Can you restate those one more time?
Yeah, so having a calcium score of 0 is ideal, right? That implies that you do not have any plaque that's calcified or hardened over. Once you get to a calcium score between 1 to 10, that's minimal. 10 to 100 is mild. 100 to 300 is moderate or intermediate, and anything above 300 is severe. What we are emphasizing is your risk of having a cardiac event. So minimal versus severe, right? Or high, I should say. One thing I will also emphasize is a lot of times we like to compare what your calcium score looks like compared to somebody else who's the same age as you, the same gender as you, and the same race as you. Because even though you may present with an absolute calcium score of, let's say, 50, right, which places you in that mild range, compared to somebody your age, it may actually be much higher, because somebody that's in young, let's say in their 40s or so, we really should not have evidence of calcium. It should be 0 for all intents purposes. So this allows us as clinicians to look at something called a percentile. And if your percentile is above the 75th percentile, that implies that your calcium score is higher than 75% of the population that fall in your age, fall in your race, fall in your gender, then you definitely are in that higher risk. And you may also benefit from being on these agents, such as a baby aspirin and something to lower your cholesterol.
Is that stratification being done at some of these bigger imaging centers, or is that specifically done in like a cardiology office?
So we're trying to encourage all of the, a lot of times radiology centers are doing calcium scoring, et cetera. We're trying to encourage them to standardly place it in their report. They are not doing it standardly, though, unfortunately. And again, that's where I think having the ability for our patients to understand, well, maybe even though my absolute number is this, I want to see how I compare to somebody my age that, is the same race and gender as I am, because there may be a difference, and you may actually be in a higher risk category. So that's where having that conversation with your clinician comes in. It doesn't have to just be a cardiologist. It's a very simple equation called the MESA calculation, which is multi-ethnic score for atherosclerosis. They could just type it in, and then the doctor or clinician can just put in the things that they need, which are usually age, their sex, their race, and what the actual total score was. And then it will come up with their percentile, basically.
Oh my gosh, there's so much work that needs to be done in this sphere. So many gold nuggets here. Can you talk a little bit about statins, what those are. You know, kind of in my sphere of medicine, we all hate statins. We're afraid of them. You know, talk about statins. You know, there's this issue with like numbers needed to treat, and I've seen people cite this data and that data. Provide some clarity there.
Yeah, so statins are medications that help to lower one's cholesterol. They've been around for several decades, and I do believe that unfortunately they have been given a very bad name. What I will say is that they can be life-saving when used on the appropriate patient population. So patients with secondary or for patients for secondary prevention, meaning they have underlying heart disease or cardiovascular disease, which again could be a stroke, heart issues, or plaque in the arteries of the leg, they without a doubt would benefit from the addition of a cholesterol medication such as a statin. In other situations now, we have these tools where we can calculate what one's risk is. I keep bringing that up, but it's very important that your clinicians are doing this on at least, if not an annual basis, every few years, where they're readdressing what your overall risk of having a cardiovascular event is. Because if your risk is intermediate or greater, it is suggested that you're placed on a statin. We also know that other situations where automatically you'd be placed on a statin is if your bad cholesterol, which is your LDL cholesterol, is greater than 190. Why? We know that that LDL cholesterol is the most likely particle in the lipid panel that's going to cause plaque to build up in the artery of your heart. And that's a very severe range. Your chances of having that plaque build up if you don't correct it is very, very high. We also know that patients that have diabetes between the ages of 40 to 75, whose bad cholesterol ranges anywhere from 70 to, again, anything above 70, would be suggested for being on a cholesterol medication for primary prevention as well. Why are statins given a bad name? Because a lot of times patients worry about the side effects of it. What I will stress is many of these side effects are very rare. A lot of the common side effects that people raise are muscle aches and pains and discomfort. What we will say is that we've done so much research on this, and what we've noticed is that patients that complain of those muscle aches and pains, even though we put them on a medication that they thought was a statin, but it was a placebo, as an example, they still complained of those muscle aches and pains, which helps us to determine that it's more knowing that you're on this agent than actually the agent itself causing these symptoms. I don't want to, decrease the fact that there are some people who do have those muscle aches and pains from statins, but we've gone a very long way in the pharmaceutical field right now where we're able to have different classes of statin therapy. So if you didn't tolerate one, we could always switch you to another. We may alternate the days that you're on it. That usually helps. And sometimes even anecdotally, I have found that the use of a supplement, coenzyme Q10, 200 milligrams daily
I
or
was going to
more,
ask you.
it has helped in a large number of my patients. I also will say that patients who are vitamin D deficient are more prone to those muscle aches and pains. So that may be a situation where we actually think about using vitamin D supplementation as well. But for the most part, statins are very well tolerated. And if your clinician thinks that there is benefit to the use of it, I really encourage you to have that open conversation with them, because the likelihood is you're going to tolerate it very well.
Awesome. Awesome. There's also this big component of addressing the inflammation of the rheumatic disease,
Yeah.
and decreasing heart disease risk. And that's kind of a tough one to sort out, because I find that a lot of these folks who are more vague in presentation aren't approached sensitively. Do you see anything like that? Maybe somebody has something unspecified, they're coming into the office, you see high risk of heart disease, they're in their 20s or 30s, and you're like, what the heck is going on here?
Yeah, no, I see it quite often. I mean, I do tend to, for my practice, I get sent a lot of different patients that maybe uh, no one knows what's going on, and they want to kind of get me involved to see, well, is it possible that there's a heart related condition going on? So that's where instead of kind of reinventing the wheel, I like to take a step back and look at what the workup has been to date. 9 out of 10 times they may have had all the things that I would have wanted to look at already drawn in terms of blood work or imaging, etc. And if they didn't, then that's where we have that different, more thoughtful conversation. But I agree that there are situations where we don't know what's going on, but that's where that collaboration and working together comes into effect.
Awesome. Is there like a network of kind of more cardio rheumatology focused providers that people can look up, or clinicians can look up to send patients to, or patients
Well,
seek out?
yeah, so there's not a network nationally or even in the state of Arizona, unfortunately. What I will say is that a lot more of the larger academic institutions do have websites where they'll emphasize their cardiorheumatologic program. What I would suggest is maybe placing it in Google, based on your location, and you should be able to hopefully find a center. It doesn't necessarily have to be an academic institution. It could be a private practice. It could be, a smaller community hospital. But I will say that most of the time, the best person to reach out to is the clinician, because they should be the gatekeepers. They make life for you so much easier as patients. And if they don't know the answer, can help to do the research, because we also want to make sure you're going to the right location
Mhm.
and that you're going to get the best treatment at the end of the day. I wish there was a national registry as an example, and that's definitely something we could consider in the future, and it's a great idea. But to date, we don't have that.
Darn. Okay. So it comes down to communication between your quarterback, your rheumatologist, and your cardiologist.
Yes.
So tap them in the side and tell them to call up somebody. Dr. Bond, I really appreciate you being here. Running short on time here. Thank you, thank you, thank you. Your presentation was really enriching at Aura. Thanks for also sharing your favorite Disney princess and superhero.
You're welcome.
Thanks for wagging your finger at me. Do you have any final comments for our listeners here? People who are struggling to get answers, people who just want to be healthier. What say you?
Yeah, I would say again that although it's scary to know that our greatest threat is heart disease, we have to emphasize on the positive of that it's something we have control over 80% of the time. So I really do encourage all your listeners just to take control of their health. One, if they feel that they don't know a lot of the answers to the things we address, such as their cholesterol, their blood sugar, their blood pressure, ask their clinician. If they have further concerns that they feel that their clinician is not addressing, it's absolutely reasonable to ask for a second opinion. Maybe consider asking them for that referral to a specialist, such as a cardiologist, as an example, one that focuses on prevention. And that's what I emphasize, because there are many cardiologists out there who don't feel as comfortable as someone like myself to focus in on different lipid particles and other aspects. They may just want to do your classic stress testing and imaging of the heart and not necessarily focus on the preventive aspects of it. So just be thoughtful about that. And that's again where that gatekeeper, who is the primary clinician, comes into play. But you guys, if you follow those Life Simple 7, those tips that I mentioned, you are doing yourself a better service, and you're most probably lowering your risk of having any of these scary cardiovascular issues in the future. So that's
Simple
what I leave you with.
seven. Simple seven, baby. I love it, Dr. Bond. Thank you so much for being here. You rock. Thank you, thank you, thank you. Uh,
Thank you.
we'll close here. Hopefully you'll do this again in the future with me as things evolve. I'm really
Yeah.
excited, appreciate what you're doing. So thank you so much for being here.
Thanks. It was a pleasure.
All right,
Bye.
everybody. Happy Friday Eve.
Yeah, exactly. Bye-bye.
Bye.